It's 10 o'clock. I guess we'll go ahead and get started. Good morning and welcome to Dementia and Antipsychotics in the Long-Term Care Setting, a Quality Improvement Initiative. We are excited to have you with us this morning for this new web-based training series, which is a collaboration between Vanderbilt Medical Center, Vanderbilt Center for Quality Aging, and Q-Source, the Quality Improvement Agency here in Tennessee. And this is the first in a series of 6 training sessions. We'll have one session per month, so November session will be dementia and behavioral disturbances, December psychopharmacology in the nursing home, and then on down. We have modified the titles for the last 3 presentations or sessions, and you'll receive that and a schedule of all the training dates as a follow-up email to the training session. Also, we'll be doing 2 presentations of every session, an AM and a PM, and the dates for all that will be listed in the email. Also, you can find this information at our project website. The link is in your chat pane. And Britt will be monitoring our chat feature today. At this point, I want to go over a couple of housekeeping things. We have all the phone lines muted. This provides a better listening experience by eliminating the background noise. We will not be opening the phone lines on today's webinar, so we ask that you use the chat box feature. Depending on how your window is set up, the chat box will be located either on the right-hand side or on the top of your screen. And like I said, Britt will be monitoring this feature as we move through the presentation. If you have a question or a comment, you can post it in the chat and we'll respond either in the chat box or on the call. Now, so we can verify that everyone understands how to use the chat feature, please post in the chat box what facility you are calling in from today and how many people are viewing the webinar there. While you're doing that, I want to mention that we would like you to keep a record of attendance for who attends at your facility, and either email that to us or fax it to us. And if you should have gotten the attendance record sample in the invitation, if you didn't, again, you can go to our website, click under the Session 1 tab, and it'll be right there on your right-hand side. Also, while you're posting your facility in the chat, I would like to inform you that during today's presentations, you'll be asked to participate in some polling questions. So stay engaged and have fun, and when you do answer a polling question, be sure to hit submit so we can capture your answer. And we'll go ahead and try that out. The polls will open after I read the question. How would you describe your facility's current efforts to reduce antipsychotic medication use? A, we just recently started focusing on this topic and are trying to learn more. B, we have been actively trying to reduce antipsychotic medications but have experienced challenges and need further guidance. C, we have successfully reduced antipsychotic medications, but there is still room for more improvement. And now the poll is open. Go ahead and select your answer and make sure you hit submit when you finish. Maybe just put it line into. Okay. All right, we appreciate you answering. And you, okay. And it looks like everybody's in a slightly different place. Most of you are at least trying or have started this process, and we hope this series of tips will get you further along in the process. We appreciate you taking time to answer this. It will help us tailor our future sessions to your needs. But with that said, let's get underway. Today, we'll do an introduction to dementia care and quality assessment and performance improvement. For those of you who participate in the Q-Source initiative, the coffee will be hopefully a bit of a refresher and some new information. And we've got some great speakers for you today. Dr. Jim Powers from Vanderbilt Medical Center, Carrie Plummer from the Vanderbilt School of Nursing, and Beth Rocher from Q-Source. So I'm going to go ahead and turn it on over to Carrie.
Good morning. Hopefully everybody can hear me. If not, please let us know in the chat box and I'll make sure that we adjust accordingly. Just to do a quick overview, make sure there we go. The objectives for today are to provide a very quick and brief overview of dementia and the problem behaviors associated with dementia in the nursing home setting, and then to have a short discussion about the potential adverse effects associated with the use of antipsychotic medications for managing these problem behaviors, and then finally to do a brief overview and introduction to QAPI and how we can apply it in the long-term care setting to reduce antipsychotic use in this population. And most of these statistics are probably not going to be remotely a surprise to any of you since you're in the mix of it all. But when there's been surveys or polls done looking at Medicare beneficiaries in long-term care setting, recent studies have shown that approximately 64% of these residents in the long-term care setting have Alzheimer's disease or some other form of dementia. And 78% of nursing home residents with dementia also exhibit behavioral and psychological symptoms of dementia. And then 41% of those oftentimes have symptoms of psychosis, which can complicate the care for those particular patients. Care for a person with dementia requires a significant amount of effort on behalf of all of the long-term care staff, from the care partners to nurses to nurse practitioners, physicians, etc. And as the cognitive impairment increases, you see a significant increase in the number of hours required to care for that person. Some of the difficult behaviors that we see associated with dementia are things such as wandering, sleep disturbances, sexual inappropriateness, verbal agitation, physical agitation, aggression, crying, psychosis, which includes both delusions and or hallucinations. And Dr. Rocher actually is going to touch briefly on why this topic in particular, reduction of antipsychotic use, is important.
Great. Thank you, Carrie. And thank you to all of the nursing homes that are dialed in for this webinar today and to participate in this series. I just want to thank Dr. Powers and his team for this collaboration. You are part of our Leading and Sustaining Systemic Change Collaborative, and that is our ADAMA Alliance Collaborative, and many of you have been getting QAPI concepts and techniques shared through that webinar series that we have. So this collaboration with Vanderbilt is just going to enhance your work around your performance improvement project. So we certainly appreciate your attendance today. And I do, again, thank Vanderbilt for the opportunity for us. So why is this topic important? Well, as you know, being a part of the Nursing Home Collaborative, this is a hot topic, antipsychotic reduction. We've all been working on it for several, it seems like years, with the long-term care setting. But I wanted to kind of give you just a timeline, and we do have some of this information posted on our dedicated webpage for the Leading and Sustaining Collaborative. But just to refresh your memory, in 2011, the Office of Inspector General, the OIG, the Department of Health and Human Services, of course you probably know this, but they did release a report underscoring the high use of atypical antipsychotic medications. And the key word here is for off-label indications among nursing home residents. So according to the report, as Carrie has shared with you, 83% of atypical antipsychotic drug claims were for elderly nursing home residents who had not been diagnosed with a condition for which antipsychotic medications were approved by the FDA. So because of that report, in early of 2012, as a result of these findings, CMS launched a national initiative, and it was, I'll share that with you in just a moment, but it was launched in April of 2012, and that was the National Partnership to Improve Dementia Care in Nursing Homes. As a result of that initiative, all of the states became very aware of this goal around antipsychotic reduction. Here in Tennessee, as an example, we formed a long-term care coalition, THCA, Q-Source, the QIO, Vanderbilt was a part of that. So we started this discussion around the antipsychotic reduction. So that leads us, thank you for the next slide, around the CMS National Partnership. So we have been working on this for a while, and, you know, this particular webinar series is to continue our work, as I mentioned, with the Nursing Home Collaborative. Part of our goal is to reduce unnecessary antipsychotic medications. We are sharing with you, I'm sorry, go back to the next slide.
Sorry about that.
That's okay. We are sharing with you just overarching principles and concepts through our collaborative. And so with the subject matter experts that Vanderbilt is bringing to us, we can start to form those performance improvement projects around this topic. And also, another reason why this is important is, as we all know, with the long-term care proposed rule around QAPI, when this rule is enacted, nursing homes will have to have at least proof of one performance improvement project, an effective performance improvement project showing measurable outcomes. So this is a great way for us to align what we're doing with our nursing home collaborative, and again with Vanderbilt and this national initiative around dementia care to start work on this. So thank you again, and Carrie, I'm going to turn it back over to you.
Okay. Thanks, Beth. So looking at some statistics from a state level here in Tennessee, and comparing them to national levels, you can see that we're still lagging behind a little bit. And this is actually, thanks to Beth and her group, very recently updated information data that we have here in terms of the average percentage of long-stay residents who are on antipsychotics in the long-term care setting. Nationally, we have it at 18.7%. And then here in Tennessee, it's at 21.6%. So you can see that we're definitely ahead of the curve and not in a good way. CMS's goal is to reduce antipsychotic use to 15% nationally, and here in Tennessee, we're looking at reducing down to 17%. So you can see we've got a little bit of ways to go. So part of the effort, a big part of the effort is because of our understanding of the adverse effects that are associated with the use of these atypical antipsychotics. And in particular, of course, in our older adult population, they are particularly vulnerable to some of these side effects and the sequelae related to these side effects. So, for example, I'm sure you've also seen this in your patient population. We have issues with sedation or over-sedation with these medications, worsening of cognitive status, worsening actually of psychotic symptoms, restlessness, movement disorders, change in gait, and in particular increased fall risk, weight gain, and also blood sugar issues. This is a handy table that University of Iowa has put together looking at comparing the side effects of the different antipsychotics that we're typically seeing being used in the long-term care setting. And just thought this was a nice way to sort of compare them across in terms of the actual side effects. So they're comparing Abilify, Haldol, Zyprexa, Seroquel, and Risperidol. And you can see that some have certainly, for example, Seroquel is shown to have a higher sedation rate than perhaps Abilify or Haldol. However, you can see that with the vast majority of all of these antipsychotics that, for example, sedation is a side effect that you'll see with this medication. So this is a very recent comparison that's been done, basically a combination of different studies that have been done over the last decade, put into a nice comparison table here. So moving to the next. So all of this says, of course, we also understand that there are occasions when we do have to use antipsychotics in the long-term care setting. And so there are some handy guidelines that CMS put together really for prescribers that helps define when these situations allow for the use of antipsychotics when they're appropriately documented. So the CMS guidelines are, in particular, the person must present a danger to either themselves or others, or it causes a person with dementia to experience one of the following: either inconsolable or persistent distress, a significant decline in function, or substantial difficulty receiving the needed care from the long-term care staff. The important thing, I'll just emphasize this, the important thing is to make sure that if this is the situation that the nursing staff and whether it's nurse practitioners, physicians, document this clearly in the long-term care documentation. So, moving forward, how are we going to institute these improvements at your facility? And this is where we start getting into talking about coffee and PDSA cycles. So just to give you an overall sort of long-term view of this, in terms of fundamental improvement questions, we're looking at, first of all, developing an aim. What are you trying to accomplish? And we'll talk a little bit more in detail about each of these steps. After you've established your aim, then how are you specifically going to measure that there's changes that are happening? How do we start off with a baseline and then show that we're showing that there's an actual measurable improvement at your facility? And how are we going to go about making this change? So I'm sure all of you have already heard this, but we'll review this. In terms of the aim, it really helps to make it, to use the acronym of using a SMART aim, which means we make it specific, measurable, attainable, relevant, and time-bound. So we'll give you an example here. To reduce the percentage of residents receiving routine antipsychotics to manage problem behaviors by 10% in the next 6 months. So you can see there, specifically we are saying we want to reduce antipsychotic use and what our particular population is. We're being very specific about that. We're talking about it in terms that are measurable. We are wanting to reduce this by 10%. It's time-bound in terms that we want to do it in the next 6 months. It's relevant because obviously this is an issue that we've identified that is nationwide, but specifically here in Tennessee, and also with CMS taking a close look at this. It's a very relevant issue. And it's up to the facility to really decide and discern whether or not it's attainable. Is this something that we think we are able to do? You always want to make sure, I sort of joke around with my students that sometimes I have days where on my to-do list, I'll say my top number one thing to do is to get out of bed because then I can at least check it off of my list and feel like I've accomplished something. So it's not that we want to make it overly simple or overly easy to attain the goal, but we certainly want to make it so that we're not sort of shooting ourselves in the foot from the get-go, something that you think is doable within the context of your particular facility. Okay, in terms of measurement, this is really, I think, the key thing, and one of the things that you see, whether it's quality improvement or research in general, you want to make sure that what you're measuring that is data that is easily attainable. This is going to ease the burden of designing and doing this coffee project at your particular facility if you identify data that is easy to obtain, that's already being collected maybe for a different reason, but it's already in your chart. So what data can you use to monitor this particular change that you're starting at your particular facility? Develop a data collection plan. Who's going to be the person actually collecting the data? And who's going to review it to make sure the data is being collected in the timely manner, that it's being reported as it needs to be reported? And how often are you going to be checking to see if this data is being collected? Sorry, it's a tiny little arrow that I have to keep clicking on. There we go. So we need to go ahead and establish a baseline. I mean, this is really stating the obvious, I know, but we need to make sure that we know where we're starting from in order to then see that there's a difference. It gives us an opportunity to really look and see, are there other parts of this process that maybe we need to be measuring or observing more closely. And see, balancing measures, there's always the possibility that we're going to start a PDSA cycle and our goal is to reduce antipsychotic use, but then there are some other added benefit to the process. So it's always good to keep an eye on that and make sure that you are tracking all changes. Okay, so root cause analysis is a tried and true way of looking at issues that pop up in a healthcare setting, whether it's long-term care or hospital setting, and analyzing what particular factors contributed to the development of a particular problem. So we'll talk a little bit about how to do a root cause analysis and then how that sort of integrates into the plan, do, study, act cycle. So root cause analysis helps you identify the primary causes of a particular problem. What happened, why it happened, what were the factors that contributed to it, and how do we go about changing things so that it doesn't happen again. There's a couple of different tools that are provided to you, the RCA 5-WISE worksheet and also a fishbone diagram, which I believe we have in the next. Here is an example of a fishbone diagram. And you can see, and this is true in the hospital setting too, you really want to make sure that it's not that we identify the one problem is this one person didn't do this one particular thing. Because the reality is when you're working in a system as complicated as our healthcare system, it's not usually just one person that caused the problem. There are processes in place that contribute to the overall issue. An example I can think of is when we've looked at medication errors in the hospital setting, looking at what are the systems that failed that got to that point to allow that wrong medication to be given to this particular patient. So you look at who are the people involved, the patient, the healthcare providers. Was there a particular issue within the context of equipment? We're talking about things like in the room, were there things that were contributing to this person's confusion? Policies, were there ways that things are being done at the facility, the way the healthcare is being delivered that may be contributing to the problem, and procedures. So you look at the event that's happened and you have a conversation around why it happened and what the factors were. And it's important to make sure that you have this be a team discussion and not just one or two people, but actually everybody involved. Okay, so the PDSA cycle, just to touch base on this again, is plan, do, study, act. And so right now what we're really talking about is the planning part, where you're beginning to look at, okay, what is our objective, what is our specific aim, what are we hoping to measure, and how are we planning to go about in making this change? Who's going to be involved? When do we start this particular intervention? What is it actually going to be? So again, talking about the fundamental question of the specific aim, as we said earlier, a SMART aim is looking at something specific, measurable, attainable, relevant, and time-bound. Do we have any questions coming up? I'm sure we're sort of... No questions? Okay. Okay, and again, to review, we've made the specific aim. How are we going to measure it? How will we know that there's an actual improvement that has happened? So, for example, here, this facility is saying we're going to track the incidence of antipsychotic use among high-risk residents by conducting weekly behavioral assessments. And then as far as what changes can we make that will lead to improvement, we will document and implement non-pharmacological interventions for residents with behavioral disturbances. The important thing to remember with the PDSA is that it's a cycle that is continuous, and that the hope is that you start off with an initial plan, you implement that plan, you measure and see if you've had any changes, what the facilitators and barriers were for that particular implementation, and what your results were, and then you continue on and you build that next cycle. And the reason we have this this graphic showing an upward slant to it is that the idea is that you won't be starting from scratch with the second cycle. You'll be building on that first cycle, PDSA cycle that you've done. And with the ultimate goal that you're going to have an increasing success in implementing your plan, even if it's been modified. So it's really, I guess, to highlight the fact that even if something is not successful the first time around, you're not starting from scratch, you're not throwing it out. You're actually building upon that first implementation. Okay, so we have a polling question.
So our next polling question is a true false. Coffee is a new regulatory requirement facilities must adopt to avoid penalties. And go ahead and click your answer and make sure you hit submit so we can see it again.
Okay. And Greg, were you going to speak to this particular requirement?
I certainly can. Do you want to wait for them to submit their answers?
Well, it looks like it supposedly is where we're trying to figure it out here. Oh, there we go. Okay.
Okay. So, this is kind of a trick question because it read, QAPI is a new regulatory requirement facilities must adopt to avoid penalties. And it is a pending, a new proposed, Greg, it is coming. So it's not been enacted yet. So the good thing is, with collaboration with this Vanderbilt series and with our Nursing Home Quality Care Collaborative, you can practice, if you will, with also trying to reduce your antipsychotic reductions. You can practice equipping your team to conduct an effective performance improvement project around this topic. So we want you to know that it is coming. It is going to be a new regulatory requirement. The rule has not been finalized, but it is coming down the pike very quickly.
Thanks, Beth. Next, Dr. Powers is going to lead us through a case example. We will be playing an audio file for you. However, the full video file is up now on our website under Session 1. So afterwards, if you'd like to revisit it, you can visit the website there.
Hello, everyone. I'm Dr. Kim Powers. I'm a geriatrician and certified medical director. My practice is at Vanderbilt as well as with the Veterans Administration. We have chosen an authentic case to present to you. The full version with the DVD is available on the website, as you heard. We are going to play excerpts from this for you, and I'm going to let our team speak for themselves. This is our team demonstrating what we hope is a high-quality, team-based dementia care for a patient with agitation.
What stages and processes do you see families undergo when making the transition between home and into a facility?
I would say that families go through the stages and processes, mainly the stages of guilt and grief. Grief is a big one, going through the grief process of what they thought it was going to be and now what is really happening with their loved one, and educating them that they are still the caregiver. It's actually just a different type of caregiving, and that they can concentrate more on being an emotional caregiver rather than the burden of taking care of the physical part of caregiving. A lot of times we see patients come in and out of the hospital in acute care settings, and it takes the family several admits into an acute care setting before families realize that the patient is actually more safe and better off in a long-term care setting than they are at home. And so sometimes it takes several stages for the family to realize that this is better off for them and especially for the patient.
When psychotropic drugs are indicated, how do we best choose the medication and monitor for safety?
Again, that goes back to which psychotropic class we're talking about again, because there's so many of them. If we're talking about specifically antidepressants again, what we use a lot of time in our geriatric patients is going to be medications such as sertraline or citalopram that belongs to a class of medications called SSRIs or selective serotonin reuptake inhibitors. With those medications, we normally keep track of how the patient responds to them. Are they sleepy, so does it increase sedation, or does it make them a little more active? And based off of those factors, we can move the medication to the morning or the evening. And those can easily be seen by other patients or other caregivers, and they can help us by communicating with us on how we can adjust those medications to better take care of the patient as well. And so monitoring factors just by how the patient responds in those ways too. There are laboratory parameters that we check for sodium levels and things like that too. And then with antipsychotics, like we talked about earlier, those have more metabolic risks that we have to take into consideration. They can affect the patient's blood glucose or their blood sugar levels. And so we have to monitor those. It can cause some weight gain if they're kept on it for too long as well. And several other things, there are some movement disorders that can be caused that we also need to consider, especially if they're kept on the medication for long term. And so there's some testing that we may have to do at baseline and continue to do ongoing if they need to remain on those medications for long. Sedation is a big one that we have to monitor in older patients. Older patients have a harder time of removing the medications from their system, or what we call eliminating them, just because as we get older, our body has a harder time getting rid of the medications. And so they tend to hang around a little bit longer. And because they're on so many medications, you have drug interactions and other medications that can cause sedation as well. And it just, all of those things start stacking on top of each other and accumulating. It just increases our risk of drug interactions and increased risk of sedation as well. And so those are a lot of the issues that we have to look out for.
As this patient's primary medical provider, how would you approach this case?
This is a tough case. When we think about dementia and the trajectory of the illness, we think of a very interesting, unique trajectory. With processes like cancer, heart failure, a lot of times we think of a slow downward trajectory that's fairly linear. What we more commonly see with dementia is stages of stability followed by events such as medical complications that cause the patient to go into a more rapid state of decline, followed by another period of stability. And so in these sorts of cases, I find it really useful to speak with family, caregivers, support people, and other staff members and just provide them support and education about what they've seen. It can be very scary to watch your family member go through one of these states of rapid decline. And in this instance, we're going to have an opportunity to provide them with a lot of support by giving them education about the medical underpinnings of what they've witnessed.
Symptoms and processes do you keep stable?
This is Jim Dowers again, and I realize that we hadn't given you the case, so let me read that to you. This is a 79-year-old gentleman with advanced dementia who resided in the facility for over 6 months. Widowed with no family, he remained bed-to-chair functionally, independent for all of his activities of daily living, but capable of simple communication. Early each evening, he would become uncontrollably agitated. Extensive efforts by the staff to tend to his comfort, provide personal interaction, and laboratory investigation were all unsuccessful in explaining or alleviating his distress. On one occasion, an old family member acquaintance came to visit. The staff nurse, on inquiring what might cause the patient to become distressed every evening, learned that he was a former long-distance trucker who was devoted to his wife and had a habit of calling her at 6 o'clock every night, giving his location and expected time of arrival home. Staff used this information to develop a person-centered approach and initiated a non-pharmacologic management program for him, and had developed a scrapbook of memories of the patient's wife and utilized it every evening to successfully prevent the patient's agitation. This is an authentic case, and I hope it sounds like patients that you've cared for. The answer could not have come without personal information about the resident, which came from a long-time family friend. Managing residents with dementia can be very challenging, especially residents with behavioral disturbances such as verbal and physical aggression, anxiety, agitation, and those who resist care. The use of antipsychotic medications is now used as a nursing home quality indicator and publicly reported for all homes nationwide, with the rationale that the use of these medications should be kept to a minimum. Alternatively, numerous behavioral approaches to the management of agitation and dementia are available, and we hope to show you many of these examples in this series. Nursing homes in Tennessee and nationwide are under increased pressure to reduce the prevalence of antipsychotic medication use.
So that leads us to our next polling question. Another true/false. Antipsychotic medication should be used only after non-pharmacological treatment has been attempted. And the poll is open. Go ahead and select your answer, and don't forget to hit submit. Looks like people are paying attention. Good job. Drew is the right answer. At this point, Carrie's going to give us a summary, and then we'll open the floor to some questions from the chat team.
Okay, and first of all, thank you very much for attending this webinar. And a summary for this particular session is that we were looking at how antipsychotic medications are commonly used to manage behavior problems in patients with dementia, especially in the long-term care setting. And currently in Tennessee, our rate is at 21.6%, and the goal is hopefully to get down to 17%. There are numerous potential adverse effects with these medications, and some of the most problematic ones are sedation, confusion, and those can often contribute to falls, which we all know can lead to even further complications. And the CRAPI framework, PDSA cycles are really a key tool to use in the long-term care setting to provide a framework through which your team can identify how to reduce the use of antipsychotics in their population. And so we have a second presentation of this session that's going to be next Tuesday at 1 o'clock Central Standard Time, 2 p.m. Eastern Standard Time on October 27th. So if you have other staff that you would like to attend, please feel free to log on to the webinar and have them take part in it.
If you have questions for Dr. Powers or Carrie, you can send those to Britt in the chat thing. Also, if you visit our project website, you can email us questions if you have questions between sessions. You'll find Britt's contact information there and my contact information. We'll be your primary contact people between sessions. And while questions are coming in, hopefully, I'll let you know about our second session, our November session, which is Understanding Dementia and the Nature of Behavioral Disturbances. Again, we'll have a morning and an afternoon presentation for attending. These sessions will be led by Dr. Paul Newhouse, who is a geriatric psychiatrist here at Vanderbilt with a great deal of experience in this area. And again, I can feed you this information in the chat pane, but this is my contact information and Britt's contact information, the project website, and Vanderbilt Center for Quality Aging website, which has other resources for nursing homes. I will say about our project website, the slides are for this presentation are currently posted there, as well as the video that we played. And once this presentation is over, the audio from the presentation will be up on the website as well. And also there you can find a sample sign-up sheet or attendance sheet and a way to send that back to us. Beth, do you have anything else? No?
No, I just want to let our audience know that the series is going to build upon itself. I don't know if you want to maybe go back to the schedule of the topics that will be offered during this series. You know, this particular session was an introduction to get you prepared for your performance improvement project around this topic. So some of this information, I know from our collaborative, you've heard about the performance improvement techniques that Carrie shared with you, like the PDSA and root cause. So this was an introduction. This is to get you to set your aim statement around your goals. And then, as you see on this schedule, this series is going to continue to build on itself to get more into the subject matter content. So, thank you so much, and I think this is going to be a great collaboration, and thank you to Dr. Powers and Carrie for this wonderful presentation.
And again, if you have any follow-up questions for our presenters today, feel free to contact myself or Britt. And if no one has any questions, we'll see you either again next Tuesday for the second presentation of session 1, or we'll see you in November I forgot. There is one more polling question quickly before you sign off. How useful was the content of this webinar to you and your staff in managing antipsychotic medications for the residents in your facility? If you could answer that before you log off, we'd really appreciate it. And any other feedback you have, feel free to email us. Thank you all for participating, and again, we'll see you either next Tuesday for the second presentation of this webinar, or we'll see you in November for session number 2. Have a good day.